My name is Mary Sponsler, and I'm in the MSN Nurse Midwifery program with the University of Cincinnati. My presentation today is on the different pelvic types and the effects they have on labor. In this presentation, I'll be discussing how the female pelvis types are classified. I will also discuss the significant differences between the pelvis types and how labor and delivery of the fetus is impacted by these differences. Before I fully dive in, let's first review the basics of pelvic anatomy. The pelvic girdle is composed of the sacrum, the coccyx, and two innominate bones, commonly known as the hip bones. The innominate bones are comprised of the ilium, the ischium, and the pubic bone, and they are joined together by the pubic symphysis. Now let's review the pelvis. Superior to the birth canal is the false pelvis, directly above the true pelvis. Its only job related to pregnancy is to support the growing uterus. The true pelvis is directly below the false pelvis. It is divided into three parts: the inlet, which is the upper entrance into the true pelvis, the pelvic cavity, which is the main portion of the birth control, and the narrowest part of the true pelvis is in the pelvic cavity between the ischial spines. And then finally, there is the pelvic outlet. The dimensions of the pelvic inlet, pelvic cavity, and pelvic outlet affect the passage of the fetus in labor. The size and shape of the true pelvis are critical components of childbirth. The birth canal shape is determined by the location, size, and characteristics of the sacrum, the sacrosciatic notch, the side walls of the pelvis, the ischial spine, and the subpubic arch. As we compare the different pelvic shapes, these landmarks will be important. As you can see, the size and shape of the pelvis plays an important role in the labor and delivery process. Next, I want to talk about the way the female pelvis has commonly been classified through the years. The Caldwell-Molloy classification system was developed in the 1920s by Dr. William Caldwell and Dr. Howard Molloy in an effort to create a system that would help doctors identify patients who might have difficulty in childbirth due to the shape of their pelvis. These physicians studied numerous pelvic x-rays and came up with a classification system based on their findings. This system of classification evaluates the inlet, the mid-pelvis, and the outlet, paying special attention to the sacrum, sacrosciatic notch, the side walls, the ischial spine, and the pubic arch. According to this system, the characteristics of these structures help to determine the obstetric capacity of the pelvis, essentially determining the ability of the fetus to pass through the pelvis. The Caldwell-Molloy classification system identifies four main pelvic types based on the shape of the pelvic inlet and posterior characteristics of the pelvis. These four pelvis types are known as the gynecoid, which is with a circle in blue below it, the anthropoid, which has a greenish yellow oval, the android, which has a red heart, and the platyploid, which has a black, flat oval. Each of those colors and shapes represent the shape that coincides with that particular pelvic type. Let's talk about those pelvic types. The first pelvic type we're going to talk about is the gynecoid pelvis. It's known as the female pelvis because it is the most frequently occurring pelvis among women. Up to 50% of women have this pelvic shape. The inlet of the gynecoid pelvis is rounded with a transverse diameter that is greater than or equal to the diameter, which makes the pelvic inlet a round, roomy entryway, and the posterior sagittal diameter is slightly shorter than the anterior sagittal diameter. The fetus typically engages in transverse or oblique diameter with slight asynclitism. The fetus is commonly in the OA position. Throughout labor, there is good uterine function. The fetus is able to internally rotate early and completely due to the adequate space in this pelvic cavity. Additionally, the wide pubic arch reduces the risk for perineal tearing. The gynecoid pelvis is optimal for childbearing and for a vaginal birth. Some key features of the gynecoid pelvis, starting with the mid-pelvis, since we already talked about the inlet. The mid-pelvis, there's four measurements that they look at: the anterior posterior diameter, the transverse diameter, the posterior sagittal diameter, and the anterior sagittal diameter. And in the gynecoid pelvis, all of these measurements are adequate. This is a roomy pelvis. The sacrum is parallel with the symphysis pubis. The sacrosciatic notch is rounded with 2.5 to 3 finger breadths along the sacrosinus ligament. Side walls, here you can see the side walls right here near the ischial spines, are straight. And then the ischial spines are blunt. They're neither prominent nor encroaching. The outlet of this pelvis, when you look at the measurements of the anterior posterior diameter, it is long. The transverse diameter is adequate, and the pubic arch, I believe we said this already, is wide and round, which makes there to be less risk for perineal tears. The obstetric capacity of this pelvis is adequate. The next pelvis we're going to talk about is the anthropoid pelvis. It is oval shaped. Over 40% of non-white women have this type of pelvis. 23.5% of white women have this pelvis as well. The pelvic inlet of the anthropoid pelvis is oval. The AP diameter is much larger than the transverse, creating the roomy oval-shaped inlet. The anterior segment of the pelvis is pointed and narrower than the posterior segment. During labor and delivery, the fetus typically engages in AP or oblique diameter and is often frequently in the OP position. Delivery and labor are usually easy, quote unquote. However, a birth with a baby's face pointing to the pubis or sunny side up is very common, so back labor can be an issue. The anthropoid pelvis has a good prognosis for childbearing and vaginal birth. Some key features of the anthropoid pelvis. In the mid-pelvis, we talked about the 4 diameters, the AP, transverse, posterior, sagittal, and the anterior sagittal. The AP diameter is long, and the other 3 diameters are adequate. This is another good, roomy pelvis to have a baby. The sacrum is posteriorly inclined, and the posterior sagittal diameters are long throughout the pelvis, allowing more space in the posterior portion of the pelvis for accommodating the fetal head. The sacrosciatal notch is of average height, but it's quite wide with approximately 4 finger breadths along the sacrospinous ligament between the ischial spine and the sacrum. The side walls are somewhat convergent, meaning they're becoming more narrow. You can see it slightly here. It's not illustrated well, but it kind of funnels down. And the ischial spines are usually prominent, but not encroaching. The transverse diameter of the midplane is generally less than the gynecoid, but not as contracted as the android pelvis. The outlet, the AP diameter of the outlet is long. The transverse diameter of the outlet is adequate. The pubic arch is normal to narrow. You can see it's a little bit more narrow and high. And the obstetric capacity of this pelvis is adequate. The next pelvis we're going to talk about is the android pelvis. The android pelvis is known as the male pelvis because it's most common in men. This pelvis is heart-shaped and accounts for approximately 32% of all white females and 15.7% of non-white women. The posterior segment of the inlet of this pelvis is wedge-shaped, while the anterior segment of this pelvis is kind of narrow and triangular. You can see that here. The posterior sagittal diameter is short in comparison to the anterior sagittal diameter. There is limited space in the posterior portion of the pelvis for accommodating the fetal head. The android pelvis is not ideal and has a poor prognosis for having a vaginal birth. The fetus typically engages in a posterior or transverse position. The fetus is typically asynclitic as he or she descends into the pelvis. These babies usually have lots of molding, and there's an increased incidence of forceps application, rotation, and extraction to help the baby out. There can be a deep transverse arrest with OP position due to the failure of the fetus to rotate. Finally, the narrow pubic arch on the android pelvis oftentimes leads to major perineal tears. So some key features of the android pelvis. The mid-pelvis measurements, the AP diameter is reduced. The transverse diameter, reduced. Posterior sagittal diameter and anterior sagittal diameter all are reduced. It's a much more narrow pelvis and with less room to move around. The sacrum is anteriorly inclined and flat. Sacrosciatic notch is highly arched and narrow with approximately 1.5 to 2 finger breadths along the sacrospinous ligament, which is much smaller than the other pelvises. The sidewalls are usually convergent, and this is typically known as truly a funnel pelvis because of its converging sidewalls. The ischial spine is prominent and frequently encroaching, thereby decreasing the transverse diameter of the midplane. The outlet, the AP diameter is short, the transverse diameter is narrow, and the pubic arch is narrow and deep. The obstetric capacity is adequate, and there is a poor prognosis for a vaginal birth with this pelvic type. Finally, the last pelvis we're going to talk about is a platypoid pelvis, and it's known as the flat female pelvis. It's flat-shaped. 3% of all females have this, and it's very rare. It is the widest of all pelvis types and very shallow. The opening of the pelvic inlet is flat, and there's a very short AP diameter with wide transverse diameter. The anterior segment of the pelvis is wide, as I keep saying. It's very wide. It's the widest of all pelvises. In labor, the platypoid pelvis is not conducive to vaginal birth. The fetus usually has marked asynclitism. The head engages in transverse diameter. It is almost impossible for the fetus to rotate and descend through the pelvis. Delay in labor progress begins at the inlet. So some key features of the platypoid pelvis. The mid-pelvis diameters, the AP is shortened, the transverse is wide, posterior sagittal diameter is shortened, and the anterior sagittal is also short. The sacrum is posteriorly inclined and hollow. The sacrosciatic notch is wide and flat with an acute angle between the ischial spines and the sacrum. The sidewalls are slightly convergent, becoming more narrow. And the ischial spines are somewhat prominent, but because there's such a wide transverse diameters throughout this pelvis, the prominence of the ischial spines really has no effect. And the diameters of the outlet, AP diameter is short, transverse diameter is wide. The pubic arch is quite wide. It's the widest of all pelvises. And the obstetric capacity of this pelvis is inadequate, and the prognosis for vaginal birth is poor. So, in addition to the four main pelvises, it's important to remember that there are many variations of these pelvis types. Many women have a combination of these features from one or more of these pelvises. Additionally, there are also categories of pelvic abnormalities. Abnormally shaped pelvises are associated with problems at delivery due to the fetus being able to adequately rotate and maneuver through the pelvis. Briefly, I want to mention several pelvic abnormalities. The H264 minor pelvis is normal in shape, but overall has smaller dimensions. Nagel's pelvis is asymmetrical due to abnormal bone formation on one side. And finally, Robert's pelvis is due to abnormal bone formation that is bilateral. The pelvis plays a critical role in labor. The ability of the fetus to rotate and descend through the true pelvis is dependent on adequate pelvic size and shape. The Caldwell-Molloy classification system was developed in the 1920s to identify women who might have problems during childbirth due to the size and shape of their pelvis. According to the Caldwell-Molloy classification system, there are four main types of pelvises based on their shape. The gynecoid pelvis is the most common, and it is round. It is optimal for giving birth. The anthropoid pelvis is oval, and it is adequate in room. It has a good prognosis for giving birth. The android pelvis is heart-shaped. It is very narrow. It is adequate, but it does have a poor prognosis for giving birth vaginally. And finally, the platypoid pelvis has a flat inlet. It has inadequate room in the pelvic cavity. It is the rarest of types, and it has a very poor prognosis for giving birth vaginally. Additionally, abnormalities of the pelvis exist and are classified according to the disorder they demonstrate. I hope this presentation was informative for you. Thank you.